All right, suppose we'll get going. Hello, everyone. Welcome to the second Winehouse series. I am Ellen, your host, along with Ben, and we are very, very excited today to have Dan Chonde giving us a lecture about the clinical interpretation of MRI. If you don't know Dan, he could talk about a lot of exciting stuff to us today, but we narrowed it down to this topic, and he's very, very qualified as he did quite a bit of stuff for his PhD. He holds a PhD and MD as well. He did his PhD here at Martinos under Cipriani and Katana, where he developed the PETS software that is used in the brain PET MRI specifically. He also went on to do his MD, and now currently he is a clinical fellow in neuroradiology at MGH. Dan, if there's anything else that you would like to include, feel free to add a little bit more of introduction to yourself. But before we get going, if you have any question, please use the Q&A box, and we'll get through these questions later on. And Dan, take it away.
Perfect. Awesome. Thank you so much. Hey, everybody. My name's Dan. I know many of you. It's nice to see you. And it's great to have the opportunity to come teach you guys something that we don't get a lot of at the Martinos Center, which is that clinical side. Hopefully, I have a really short slide set here, just 30 slides. Knowing how I talk, it'll probably still be like 45 minutes. But my hope is this is just kind of a primer to see if you all like this and you find it useful, because one thing I noticed when I was at the Martinos Center is I didn't get a good sense of what goes on in the clinical world and what are the limitations of like the clinical environment and how that should impact how I think about what projects or science can translate versus not. Similarly, when I was, a yellow badge or a green badge sitting at the scanner, being able to look at an image and determine whether or not that's like a, oh, I need to get someone, or, oh, that's like a nothing thing. So let's click around. So here's the outline. Like I said before, you can consider this a down payment on teaching you guys how to be clinical radiologists. Hit an overview of what clinical radiology is, talk about some sequences, and then give you kind of like the first half of what, as a clinical radiologist, I sit at my workstation and look at for every sequence. So the purpose of brain imaging is really looking at structure. Brain MRI is all about structure. Brain PET clinically is the only thing that's really more about function. Now, we don't do a ton of fMRI here. Typically, fMRI in a clinical space is reserved for pre-surgical planning, because if you're going to cut out a tumor or burn an epileptic focus, you want to make sure you're not going to stick your probe through the motor strip and then the patient can't move their arm, right? Or heaven forbid, can't breathe afterwards, right? So you want to avoid the brainstem. Similarly, the important thing is MRI uses non-ionizing radiation, which is of benefit for us because that means we can perform MRIs on children for trauma. A kid falls, bumps his head, mom or dad is concerned that maybe he has a little bleed in his brain. MRI is a great way to take a peek at that. We use it for pregnant women. Very common for pregnant women to get appendicitis or have kidney stones or gallbladder problems. Using MRI allows us to avoid irradiating the fetus, which can have consequences on fetal development. Now, what is a radiologist? In the end, we're kind of like bakers. We follow recipes, and our expertise is having a good, like a baker of bread, right? If you bake enough loaves of bread, you can look at that flour and touch the flour, and how that flour is going to make that bread, or how that oven is going to cook that bread, and you're able to account for all of these things. That's what the radiologist does. We have a good sense of the imaging modalities. Now, obviously not to the degree that a scientist would with the nuances, but we have a very strong working understanding of them. We have, more importantly, the understanding of the anatomy and the appearance of pathology on those imaging modalities. And then finally, we're able to translate another doctor's request for what they want to look for into what type of imaging would be most ideal for that. Similarly, we don't really care for patients except when they're in the scanners or we're performing an image-guided procedure on them. In that case, that patient becomes our patient. And, you know, if their heart stops, it's up to us to try and revive them, or if they have a contrast reaction, like an allergic reaction to gadolinium, it's our responsibility to try and revive them or reverse that anaphylactic reaction. Now, as far as the training for radiologists, we do medical school. We do 1 year of clinical medicine, and that's called our intern year. It's either in internal medicine, pediatrics, or surgery. And then we do 4 years of a residency in radiology. Here at Mass General, 3 of those years are in general radiology, and then 1 year is in a special field where we spend a whole year just in one field. And then after that, we tend to do something called a fellowship, which is advanced training in a single field. So for me, as a neuroradiologist and a nuclear radiologist, that'll be the equivalent of 1 year in nuclear radiology, which is PET and gastric emptying studies and nuclear studies, and then 1 year in neuroradiology. All right, now, everything starts off with clinical protocoling, right? Clinical protocoling is the act of turning your nephrologist's request, that's a kidney doctor, or your internal medicine doctor's request for a patient, into the proper type of imaging sequences. So in this case, you have, we have Superman here, 39 male, who has mental status change, and that just means he's confused. This can happen for a whole number of reasons. So it's up to us to figure out what sequences of images is going to give us the best result. Now, of course, we as radiologists, we focus on reading the images, and we have radiology technologists who perform the scanning. So we have to communicate with our technologist colleagues and to tell them what sequences of images need to be acquired, what the size of those images are, pulse timing, etc. And the way we do that is through protocols. So we would select a protocol. And what a protocol is like a recipe. So here is at Mass General, here's an example of our adult MRI neuroimaging protocols. It's just a PDF file with a bunch of different protocols or recipes. And we write the recipe we want. And then we give that to the technologists, and then they have the similar book, and they look at what images are included in that protocol, and then they program them up in order for the scanner. And so here, typical scan would be just a routine brain with contrast, and that would have a collection of sequences. And then that would get performed in the patient. It gets sent to us. And then based on those images, we're able to determine whether or not certain pathology is present. Not all pathology, but just certain pathology. And the reason we wouldn't run every single sequence on every single patient is because it wouldn't be feasible. It would take too much time, which means we wouldn't be able to see patients in a very high throughput manner. And essentially, a lot of that information would be unnecessary or redundant. So day in the life, right? as an academic radiologist, you're reading somewhere between 30 and 40 scans in an 8-hour shift. So that's 5 scans per hour. Over here on this side, I have the type of scan and the number of images in that scan, which I think were just some 40 consecutive scans or something, just to find an average. And here, one of those scans had 15,000 images. That was a research scan, but we still have to read those, of course. Now, as a radiologist, we're responsible for looking at every single image. And if there is a finding on that image, doesn't matter if it's on slice 1 or slice 100 or slice 1000, it's our job to see it. And if we don't see it, we are liable. So anyways, if we knock out that research scan and we just take the average of these 39 consecutive studies, there's an average of 1,027 images per study. Now, if I'm going to read 30 scans in an 8-hour shift, then that comes out to be about 1.1 second or 1.1 images per second. So 1 image every second. That's what my brain has to process and look for issues in. Now, this is a problem, right? Because that's not a lot of time and that's a lot of images. Now, there are legal cases where patients have sued clinicians, sued radiologists, and the amount of time that they spend per image has been used to sway the jury. So here was this case where this guy comes in, he had like fallen at home, there was a brain bleed, also called subarachnoid hemorrhage, and the radiologist missed it, right? Well, that's a problem because the guy ended up getting sicker as a result of it not being seen, and there was a delay of care. Now, the lawyer went back, and because all of our information is time-stamped, when we open a study, when we sign the study, they were able to see that he was reading these studies at 2 images per second. So they were saying he was going too fast and he missed it. But the fact of the matter is, as there's a higher reliance on imaging, you're going to have to be quicker. We have to find ways to be more efficient. And, had he not missed the brain bleed, this wouldn't have been an issue. But the fact that he did miss it, that's a big issue. So with that in mind, we jump into clinical radiology. And so the first question, and I'm gonna teach you clinical radiology, or the basics of clinical interpretation in the way that I look at my images. So the very first image that I'm going to look at is here. Obviously, this doesn't lend itself to a kind of informal discussion, but take a couple seconds and think about what kind of image is this. This is a diffusion weighted image, right? This is an axial image. That means it's through the transverse plane of the head. We use this for looking for strokes, or we call them infarcts. Or infarcts is another term for strokes. Now, this is one of the most important images because if there is a patient who has a stroke, there is a certain amount of time during which you can give them therapy for that. So it's important that we catch strokes immediately, and it's important we don't miss strokes. Similarly, the stroke is going to be the thing that you can have the biggest impact on. Now, this next image, this looks like the last image, except you see bright stuff where there should be fluid. This kind of curvilinear part here, which looks like back-to-back C's almost, or maybe 3s, these are the ventricles. And this is generated from that diffusion weighted image. This is your apparent diffusion coefficient map. So this is an axial image, which is generated from your diffusion data set. And this allows you to find areas of something called diffusion restriction. So essentially, something that is bright on your DWI, you will then look at your apparent diffusion coefficient image. And if it's dark, then it has restricted diffusion. And what that means is either there are too many cells and the water outside of the cells can't kind of bounce around in Brownian motion as freely as it wants, or the cells are so swollen that there's not a lot of extracellular space for that water to bounce around. So there's restricted diffusion. Alternatively, if you put a glass of water in there, it would be bright, just like your ventricles are bright. Your ventricles are full of cerebral spinal fluid, and they're bright because water can move wherever it wants, as happy as it wants, so things are bright. You just remember ADC, when things are sad, they're dark. All right. Now, the next imaging sequences we're going to talk about, actually, I did these things in reverse order because first we'll talk about T2, then we'll talk about a flare. Now, the T2 image itself is just imaging essentially your fluid in the brain. Now, the brain itself is juicy, squishy, so it has some fluid signal as well. But as I said before, the cerebral spinal fluid that the brain is bathed in is also bright. Now, what do we use these images for? We use these images really for one thing, and that's to look at the flow voids. If you look here, you'll see these dark spots. These are mammillary bodies, but these are your flow voids, and you see this kind of curvilinear black spot here and here. These are vessels, and we can see vessels really well on T2 images. And what we do is our eye just follows those vessels from slice to slice, and we'll follow up one along its course and make sure that it's a continuous line. Because if the line suddenly stops, or if the line goes from black to then bright, that tells us that there might be some sort of clot there. So then we're going to request additional imaging to look at blood vessels. Now, we talked about T2, and this is a flare image, which is a fluid attenuation inversion recovery sequence, also axials. This is very similar to our T2 image. The only difference is we've removed the signal from bulk fluid, from just like true fluid. So what we see with these images is we will look for swelling. So this will be important because you can see, let's say you bump your head. You see a protocol for a low-grade tumor, what sequences are included in there. We will definitely talk about that. So you bump your head, you get a little hematoma, which is a swelling under the skin. You bump your head really hard, your brain can get swollen, just like your forehead can get swollen. And that will show up as T2 bright signal. And as far as this low-grade tumor is concerned, we will actually see a case of that at the end. So I will save that for then. Now, the next sequence here is our susceptibility weighted sequence. This is a sequence that looks kind of like a T2 or kind of like a flare image, but we see all of these additional lines. Now, this is just a gradient echo sequence, which means it's very susceptible to T2 star effects. Now, the important thing here is anything that is paramagnetic is going to create some artifact. And we can use that artifact to say that there is something mineralized in that area. Now, what's mineralized in the brain? Well, things that are heavy in iron in the brain would be blood. So if blood escapes a vessel and it's just kind of sitting around in the brain, which is called an interparenchymal hemorrhage, that would be something that we would pick up here. So we use these susceptibility weighted images to look for hemorrhage, and we can also use it as a really quick way to look at veins. Now, after I've gone through all of those images, the next thing I'll look at is this image. Now, this is just a really standard T1 axial pre-contrast brain. The important thing here is it sagittal? All of the other images that we've been looking at up to this point, they've all been axials. So I haven't been able to get a good look at the midline structures. Using this T1 sagittal, I can look at those midline structures. And what are those midline structures I'm concerned about? Well, here's your pituitary gland. If your pituitary gland is flat, that tells me something. If you have a tumor in your pituitary gland, so it's all big and lumpy bumpy, that tells me something. Here's your corpus callosum. This is the thing that connects your right and left brain. I want this to stay plump and I want it to stay together. And if there's any issues with the corpus callosum, then I can start to go down a list of things that could be the cause. Similarly, we can't see it here, but you have your pineal gland here. You can get something called a pineal blastoma or other tumors of the pineal gland. This would be the best way to look for those. Which is so really the sagittal itself, you're really just looking at this midline image, but you're also responsible for looking at the other images. And just like I said before, while each image itself has really only one thing that you do with it, like on the T2, you're really just looking for vessels, you still have to have that peripheral vision to look at everything else in a given slice of that image to be able to pick it up. And then here is something probably we are all very familiar with. This would be our MP-RAGE or Bravo sequence. And this is just a contrast enhanced sequence, which is kind of T1, kind of not. We collect these images whenever we're doing post-contrast imaging because they're 3D sequences, which means on the fly, we can reorient the image. So we can look down either the barrel of the internal auditory canal, or we could move it in such a way where if the tumor is, you know, kind of shaped in a really weird direction, we can get accurate measurements of it. And of course, the benefit of this is looking for your enhancing lesions. All right, now this is kind of like the bonus rounds of things. So everything I did before pretty much covers, you know, 90% of the images that we read. This is the additional stuff you would ask for. You have your arterial spin labeling, where you can look at perfusion, and you have multiple perfusion metrics. And really, believe it or not, right, we spend all this time with quantitation at the Martinos, but all we're looking for is it symmetric? Does the left side look like the right side? And then, of course, here's our CBF. We don't get CBVs. And you just use it to also look, is that thing on the ASL also here on the CBF? Now, this looks like our T2 sequence. We're much lower in the brain. This is at the brain stem. And this is like a super high resolution T2 sequence. It's called a KISS or a Fiesta sequence. It's a 3D sequence, and we can see really, really thin structures. So when we look at the cranial nerves, that's what we're looking for. Now, we have our brain, of course, and we have our brain stem and our cerebellum, that little tennis ball that sits off the back of our head. But the way that we control much of our face, much of our head, is through cranial nerves. Cranial nerves are a set of 12 nerves. Each nerve has a very specific purpose, right? Like cranial nerve 1 is going to be, oh man, I don't even remember what this is. I think cranial nerve 1 is olfactory, and then cranial nerve 2 is optic. Obviously, these are not the cranial nerves that we typically worry too much about. It's cranial nerves 3 through 12. But we can move through these images, and we can actually look at each cranial nerve. Now, I can tell you that these little lumps right here and here, these are cranial nerve 5. And I know that because I've seen a bunch of these, so I know what cranial nerve 5 is going to look like. Part of the job of a radiologist is to being able to look at an individual slice and to to recognize what's here. I can tell you this is just some snot in their maxillary sinus, and here's their nasal septum, and here's the kind they're called concha. Here's the nasal turbinates. Yeah. All right. And so, like I said, we look at our cranial nerves here. So then we also have our vascular imaging, right? Because a big part of neuroradiology is looking for strokes. So what we do is we do this is called an MR angiography, right? We use a time of flight sequence, and these are the raw images on the right side, and we can see that the blood vessels are bright. And so what we can do is we can go to the very first slice of our stack, and we can follow the blood vessel slice by slice, see where it goes. And because we spend so much time with anatomy, we know where the blood vessel should be going. And if for whatever reason it stops, then we can say, hey, you know, we're concerned about a stroke here. If there's a little outpouching somewhere, we can say, hey, I think there's an aneurysm here. If there is a weird path that it takes, we can say there's some abnormal variant here. And so we can do that with each of the 4 blood vessels that come into the skull. So the 4 that we are concerned about are going to be our left and right internal carotid arteries, and then our left and right vertebral arteries. And if we take our stack of images and we generate a maximum intensity projection, so essentially I smash all of these volumes into a single 2D projection. And then I say for each voxel or each kind of like ray, I want the highest pixel value to be on the representative map. We can generate these projections. And so we can look at these projections and say, here's going to be my right vertebral artery, here's my left vertebral artery, combining into the basilar artery, and then my right and left posterior cerebral arteries. So then kind of like right around here on either side is going to be my posterior communicating arteries, which will then talk to my internal carotid arteries as they come down. And then this would be the middle cerebral artery, anterior cerebral artery. These would be our posterior, inferior cerebellar arteries, et cetera, et cetera. Now, in the head, which is relatively small in size, we can just use our conventional time of flight sequences. We can use those same conventional time of flight sequences in the neck, but they look kind of like garbage, right? You get something like this. And if you come back here, you get you see these nice, pretty pictures of the vascular trees. Over here, not so pretty. Similarly, we typically collect these in the coronal plane instead of the axial plane. So then we have to reformat those images to generate these axial pictures. Now the alternative, right, because this last one looked like garbage, is we can actually give the patient gadolinium when we're doing this time of flight sequence or this angiography sequence, and the signal increases X-fold. So here we can look for stenosis or occlusion like a boss. But the same thing holds true. We collect these in the coronal plane, and then actually, no, the prior we collect in the transverse plane. These we collect in the coronal plane. And the benefit here is we're able to actually see these structures at the branch points, because your common carotid artery splits into your internal and external carotid artery typically kind of like in the coronal plane. All right. Finally, we talked about arteries. Let's talk about veins. We can do similar sequences for something called a venogram. These venograms really are just to look at these major sinuses. So all the blood will drain through this superior sagittal sinus or the straight sinus. It'll then go into either the left or right transverse sinuses or an occipital sinus, but we don't need to worry about that. Then into the sigmoid sinuses, and then down into our jugulars. These typically have a lot of signal corruption. They're relatively low quality, but what we're looking for is large obstructions, so large blood clots that have made their way here, which are preventing flow. So it's usually quite dramatic when they're there. And typically, the patient's clinical history helps us decide whether or not we're going to pursue this type of imaging. And so we have a sense of what we're going to look for. Additionally, there's something called intracranial hypertension, which can actually make these transverse sinuses relatively small. They get all crunched up because the pressure inside the skull is so big. It's like if you were overfilling a water balloon and you had another little water balloon and it starts to get squished. All right. So those the basic images, right? Now, the next step is always going to be search pattern. How do I put these things into my recipe? Because it doesn't matter if I am reading a 32-year-old woman brain MRI for headache, or if I'm reading an 89-year-old man's brain MRI for a fall. One of the important things for a radiologist to kind of keep pace with that one image per second is everything has to be the same. Your eyes are going to the same place. The image sequences are always going to be in the same order, and you're always doing the same thing again, 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 again. So this is the search pattern that I use. This is what my screen actually looks like. You all can't see it, but I have two screens here, both in portrait mode. One screen will always have these first 4 images. The other screen will always have the second 4 images. And for me, I can't even start to look at a study until all 8 of those images are in the right place. And then when they are, I can quickly just read the study. So here are just some cases, right? So here's our first case, is what a stroke looks like. So here we have our diffusion weighted image. And you can say this is not subtle, right? This is bright on diffusion. And then here's our ADC, and it's dark on apparent diffusion coefficient, which means it has low diffusivity, which means it has restricted diffusion. This means the cells in the brain have been deprived of blood, so they're all angry and dying, and they're swelling up. And as they swell up, they're taking in all that fluid from outside of the cells, and then the available fluid outside of the cells is decreasing, so it gets a restricted diffusion. Now, here are how we think about that, right? Because the brain gets blood from our carotids or our vertebral arteries, and then we have a network of vessels. And these vessels, branch, and then they branch again, and they branch again, and branch again, et cetera, et cetera. So because everyone has relatively similar pathways of blood flow, that means if we were to block off one of those vessels, right? Like if we were to take one of those hoses and cinch it off, certain portions of the brain would lose blood. And these are called our vascular territories of the brain, right? And of course, here is something called an angiogram, where you stick a little catheter in one of the carotids and you squirt some radio-opaque dye, and you can actually see all of these arborization, the tree of one half of the brain. And let's see, I'll assume you can see my mouse. Here we'll see the ophthalmic branch of your internal carotid artery. And then here will be your anterior cerebral artery. Coming right out at us, right around here, will be our middle cerebral artery. And then back here will be our posterior cerebral artery. And our middle cerebral artery will branch into an inferior and superior division. And this right up here will be our superior division. So your blood clot that gets flicked into your brain and gives you a stroke is always going to end up along one of these paths. Now, this is one mechanism for which you can have a stroke. There are many different mechanisms. So if you have something like this, which would translate to a territory in the middle cerebral artery, then you can say with relative high confidence that this is a stroke, an embolic stroke. So, you know, based on all of those different flow patterns, we can generate this map. Here's our anterior cerebral artery circulation. Here's our posterior cerebral artery circulation. And here's our middle cerebral artery circulation. Similarly, areas between the two are called our watershed zones, and those are going to be the most susceptible to when you have not complete loss of flow, but when you have reduced flow. So if you have something like a blood clot that doesn't fully fill the vessel, but only partially fills it, and like a little bit of blood can get by, these are going to be the regions that don't receive enough blood. All right, now, as I said before, it's important that we know variance in the arterial anatomy because that can change what this map looks like. Now, we talked about our stroke on the last slide, and that was a middle cerebral artery stroke of that was hitting a major vessel. Now here, I don't know if this is projecting well on your screen, I hope it is, but you should see a couple little small bright dots here. And then you can see this bright area here and these bright dots here. You can see a little bright dot here. Then you can see some bright dots here in the back. And then you see a bright dot here in the cerebellum. Now that's fundamentally different from the last image where it was like a large confluent area of loss of signal. And here we see all of these little speckled areas. So this also is a stroke because I can tell you it's also dark on ADC, or all of these little spots are dark on ADC. But the mechanism is different. So for the first one, they flicked some big clot off of maybe a, maybe their carotid ruptured an atherosclerotic plaque, and it threw a big clot which got lodged in the MCA. Here, what had happened is a neurosurgeon, the people here who do angiograms where they stick those catheters in and squirt that dye, well, obviously they have to work that catheter up. And as they do, that catheter can kind of brush against the walls of the vessels, and it can cause little pieces of blood clot as it moves up there, little pieces of atherosclerotic plaque to break free and then shower your brain. And you can have like these little tiny strokes. And, you know, sometimes when they're little tiny strokes, they're there for a little bit and then you fully recover. Sometimes when they're a little bigger, you don't recover. That's just an unfortunate risk of the procedure. What is the distortion on the right side of the brain? Very good question. So these are generated using an echoplanar imaging technique, which means it's going to be a gradient echo. And this was actually created by something called a VP shunt, so a ventriculoperitoneal shunt. As you can see here, the patient's ventricles are much bigger than the ventricles we've seen on the prior studies. What happens is if the cerebral spinal fluid is created inside the ventricles, it starts in the ventricles, then it sneaks its way out through the base of the brain, makes its way into the spinal canal, then it comes all the way up, comes around the top of the brain, and then gets absorbed into our venous sinuses. But when there's some sort of obstruction and it can't escape, it just slowly starts to fill up the inside of the brain, and these ventricles fill up like balloons. So one way to kind of fix that is to stick a catheter in, and then that allows us to actually drain off that fluid. And what we do with that, which is really weird, we stick that catheter in, And then we stick the other end of that catheter in the patient's belly, and we bury it in their scalp, then in their neck, then across their chest, across their belly, then it terminates inside of their belly. So as the fluid pressure builds up inside of their head, it goes through this tube and into their belly, where our bodies just absorb it, and then it gets dumped into our urine. Now, strokes. If you see a stroke, so if you're looking at a diffusion weighted image and you see something bright and it's dark on ADC, that is a time where you really need to let whoever the supervising doctor is know, because that's when you can really help a patient. Because as time progresses with a stroke, brain tissue is dying, and there's no way for us to bring that brain tissue back after it's dead. Now, those are like the things that you will probably rarely see, but is a huge emergency. This is, on the other hand, is something you will very frequently see, especially in older patients, but is not an emergency. Now, these are FLAIR images, and all these images show the same thing. We see this kind of like T2 bright signal around our ventricles, and we see it interdigitating between the gyri, and it's kind of randomly oriented. Here we have a coronal slice, so the slice kind of like a halo, like a corona. And you can see, so here would be, you know, our, here's the top of our head, and here would be our jaw. So here we can see that they're randomly distributed. Some touch the ventricles, but they're not necessarily going into the corpus callosum. This is just, no one ever uses this word, so I don't really even know how to say it, leukocoriosis, or spots and dots. It's a very non-specific finding. Essentially what this means is, typically in an older patient, this is because they have high blood pressure. And as they have these high blood pressure episodes where it's not controlled, the blood vessels start to push, or the blood vessels start to become leaky, and then the tissue around it starts to scar down, and it becomes bright on this sequence, on these FLAIR sequences. However, these spots and dots are very non-specific, and they can mean a number of other things. And so our next couple cases will kind of show what those things are. So here's the spots and dots we just looked at. And here's another image, which is not your typical white matter nonsense. Here, these were all kind of randomly distributed. Now, here is the corpus callosum. And I hope what you can see is the corpus callosum is kind of diffusely bright. And you can see that these spots they're actually like tendrils, like fingers extending from the corpus callosum coming up. These are called Dawson's fingers. I don't know, probably based on a guy named Dawson who we thought had fingers. But this is what multiple sclerosis looks like. So, you know, this kind of benign entity, which is just some little hypertension, and multiple sclerosis can look surprisingly similar. And it's our job to be able to tell those differences. Now, this is for BIN. We talked about spots and dots before, right? Now we see this kind of non-specific T2 flare hyperintensity in the, you know, parietal / periventricular white matter. Now, unlike the other spots and dots, there's not multiple, there's just one. It's kind of large. It's not having mass effect in the sense that it's not kind of pushing on this, it's not distorting the tissue around it. So our question becomes, well, what is this thing, right? Well, the first thing we'd want to know is, does it light up if we give it contrast? So we can give the patient contrast and it doesn't light up. And so then we kind of wonder, well, what is it? Well, one of the radiologist's best tools is history, and not history as in like, you know, the patient's history, but the prior images. So if we go back a year, we see that it's relatively unchanged. If we go back 6 years, we can see maybe it's there. If we go back 11 years, it's not there. So this is a thing that wasn't there 11 years ago, suddenly appeared and has been growing in size. This is cancer. This is something called a low-grade glioma. What's the difference between a low-grade glioma and a high-grade glioma? You could think of high-grade glioma or brain tumor. High-grade brain tumor is very angry. It's going to destroy everything in its path. And when we give it contrast, because it's destroying everything around it, it's going to leak that contrast into the tissues and it'll be bright. A low-grade glioma is very slow. It slowly grows, it slowly infiltrates the tissue around it, and it's not going to have that same effect. So it's not going to light up. So our low-grade glioma protocol, yeah, exactly. Low-grade gliomas do not contrast enhance. And that's, well, they can maybe mildly contrast enhance, right? Because everything's on a spectrum, of course. But for the most part, they're not going to enhance. And they can look very insidious. And the radiologist can call them incorrectly over many, many years until they convert from a low-grade glioma to a high-grade glioma. Now, if you have a low-grade glioma, you really want to take it out because a low-grade glioma can turn into a high-grade glioma. Another name for high-grade glioma is glioblastoma or high-grade anaplastic astrocytoma. These are brain tumors that do not have high 5-year survivals. Yeah. Now that we've talked about our T2 imaging and our diffusion weighted imaging, the next thing that I look at is going to be my gradient imaging. And like we said before, these are gradient echo images, and they're very sensitive to distortions in magnetic field. So let's say you have a little tiny bleed in your brain, right? Let's say, you have a little pinprick in your brain and a little drop of blood leaks out. Well, as that drop of blood is broken down by all the cells there, they don't know how to get rid of that iron. So that iron is just going to sit there. That iron is going to distort the local magnetic field. And on susceptibility or gradient echo image, it's going to show up as a little distortion, a little black spot. So this is a single hemorrhage. Now, some patients can have lots of these, and they have these multiple hemorrhages. There's a disease called amyloid angiosis, where these amyloid plaques are deposited in the brain, and then it's deposited in the blood vessels. It causes the blood vessels to be very delicate and friable, and they break and they dump a lot of blood. And then essentially you have all these little hemorrhages in your brain. Similarly, if you have meningitis, you could get a little hemorrhage. Or if you bump your head really hard, you get a little hemorrhage in your brain. Now, different from both of these, right? Because these are spots. We see here that we have these nice lines of darkness. This is something called subarachnoid hemorrhage. So we have our brain inside of our skull. Around our brain are our meninges. We have our dura on the outside, and then we have our skull. So there are blood vessels moving between the peel surface of our brains, the outer surface of our brain, to the dura. And so we have all these little blood vessels kind of traversing these different ways. And as we stretch the brain or stretch the space, we can shear off some of these blood vessels. So blood can empty into certain spaces. It can empty between the arachnoid layer and the dura, and we call that a subdural. It can empty between the dura and the skull, and we call that an epidural. Or it can empty in the arachnoid space, which is in continuity with the CSF. That's where all the CSF hangs out. And then we have kind of like free-floating pieces of tea in our cup of tea, and it can go wherever it wants. And it can settle into these little crevices into the sulci of the brain, and we call that subarachnoid hemorrhage. So if you bang your head really hard, you get a little subarachnoid hemorrhage. Similarly, if you have an aneurysm, because remember, all of our blood vessels are on the outside of our brain. So if we have an aneurysm in our middle cerebral artery and that bursts, it's going to dump a lot of blood into our subarachnoid space. And we can look on our GRE or SWI image, and we can actually see that blood as this signal distortion. And this will be linear as opposed to spots.
Very cool stuff. Thank you very much, Dan.
Yeah, my pleasure. I have to say, it was awesome to talk to him. Oh, do you have a wish list of sequences that can help you with diagnosing disease? There's so much that we need, right? Obviously, artificial intelligence that can help us determine whether or not there are more spots and dots, because sometimes developing more spots and dots over time can put you at increased risks of things. Images that are more robust to patient motion, because every patient who gets inside of that MRI doesn't want to be there. Sometimes it's, adults who are confused, or kids who are scared, or, patients who are altered. We need things that, can correct for motion, looking at things that have higher contrast. We're always looking for higher contrast, looking at things that can help us look for alternative contrast patterns. So anything. What is the clinical significance of the isotropic image? The isotropic image is that image I called a DWI image. The isotropic image itself is some combination of your individual diffusion images into a single image, which just has higher contrast.